My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. Welcome to this episode of Operate with Zen. Today, I have the great pleasure of being joined by Dr. Kevin Turner. Kevin, if you don't mind, introduce yourself to the audience.
Yeah, hi, thanks, Phil, and hello, everyone. It's a real delight to take part in your podcast. I'm Kevin Turner. I'm a urological surgeon in the UK. I've been a consultant urological surgeon for 16 years. I work in the town of Bournemouth, which is right on the south coast of the UK, pretty much in the middle. The nearest city of any size would be Southampton. Bournemouth is a seaside town with a large static population, but also a population which is swollen by the many holiday visitors that we have. And it's a really nice part of the UK to live.
That's wonderful. Kevin, many of us have been introduced to you through your work in complications, and we'll get there. But I know that's not where you started. When we met and talked, we both bonded a little bit over kidney cancer research and kidney cancer projects. So just take us a little bit through your career trajectory, kind of where you started. And I think most urologists, and I think a lot of surgeons now, are aware of your work in complications, and we'll get there. But just tell us about your career trajectory and how you ended up doing work on complications.
Sure. Well, I'm a urologist because I worked with an inspirational urologist who persuaded me that there was no greater specialty in medicine. I had set my stall on becoming a plastic and reconstructive surgeon, but I did a urology job around about the time I was making a decision about future specialty, worked with a true inspiration, Professor David Cranston in Oxford, where I qualified from, who persuaded me, and in fact many people before and after me, that there was no greater specialty than urology, for which I'm very grateful. So I did my junior jobs in Oxford and then undertook a period of pure laboratory research. I worked in an up and running lab looking at angiogenesis. Hitherto, they'd looked at angiogenesis in bladder cancer, and I turned my attention to angiogenesis in renal cancer and von Hippel-Lindau. But I did, I guess, a fairly pure, bench-based, holding pipettes, collecting samples, running gels kind of research degree. It went well. And I guess for a time I thought I might be an academic urologist pursuing scientific research, but I think there was even at that stage a nagging doubt that maybe that wasn't really for me. I did my higher surgical training in urology in Edinburgh, then a year's fellowship in Melbourne, by which time I was pretty sure I wanted to do urological cancer, and right at the end of my training went to Melbourne with my family for a year. And then came back and looked for consultant jobs and took a job in a large district general hospital, but not one that has basic sciences research attached to it. And I was happy with that. I thought I turned out to be right, that I wasn't going to be a basic scientist. And I spent the first 5-10 years of my career just establishing myself and my surgical practice, which is now actually radical prostatectomy and a radical cystectomy. And then surprisingly, and from left field, the sort of research bug just began to grow again, but not laboratory research, but research into complications.
It's really interesting, Kevin. And, I think it's important just to highlight, we grew up in an era where academics was pretty defined what academics meant and how you could have an academic career. And I think you're one of the highlights of how an academic career can take many shapes and forms now. And I think it's inspirational, especially to the younger generations listening, that you don't have to be a bench researcher to do research, but there are kind of core principles of being an academic person, asking important questions that are going to impact the field. And I'm starting to feel this way as I'm getting more involved in the academics of well-being and sustainability as a surgeon, that these may have greater impacts on our field and our profession than any of the work you and I have done in cancers that were written in journals and publications and such. So kudos to you in doing that. I think it's also really nice to highlight that about 5 to 10 years into your career, no matter who you are, you're going to get an itch, right? There's something that's going to kind of pull you in a slightly different direction. And you have to decide if you want to scratch that itch. So, was there an inciting event? Was there something that kind of brought you into this, Kevin?
Do you know, that's such a great question. And I suppose the truly honest answer is I can't really remember. And you know, when you've told a story so many times, you begin to believe your own narrative without actually being able to remember whether it's true. A bit like when everyone asks doctors, did you always want to be a doctor? Or did you always want to be a surgeon? So I can't really remember, but I am sure that part of the story was my own analysis of my own response to a complication post-surgery. And certainly involved in the beginnings of this work for me was my reflection on a cystectomy patient of mine who had been doing well, smooth post-op recovery, was approaching discharge, and then died. And actually, I now know, but didn't know then, that they died of a cardiac event from previously unrecognized critical coronary artery disease. This was before we were regularly doing cardiopulmonary exercise testing in all of our patients, which we do now. And so I didn't know at the time, but I subsequently found out that he died from something, if you allow me to use the shorthand, died from something that wasn't my fault. In other words, wasn't directly due to an action or inaction on my part. And I remember feeling relieved. And then I remember thinking, that's interesting. Why do we react to complications in a certain way? And is the way in which we react influenced by our own view of whether we were culpable or not? And I thought, that's an academically interesting question. I'll do some reading around on that. And I didn't find much. I now know there was stuff written, which I didn't find all of it. But even if I had found all of it, there still wasn't very much. So that was part of the genesis.
Yeah. And I think we all have those experiences where we go through training, we see complications, we experience complications, but they're not, once again, to use the shorthand, are complications, right? They're under the guise of, either a senior or faculty member or somebody else who's training us. And ultimately, while we may be involved, it's not our patient, our responsibility in that double quote kind of way. But then it becomes very real at some point early on in our career. And it doesn't matter, it says all the time, doesn't matter if you do big surgery, little surgery, cancer, or benign disease. You're going to experience complications that profoundly affect your patients and profoundly affect you. And this is not something we are formally educated on. And if you read any of your work, which I think I read all of it, I think that's one of your major points, is that this is not part of our curriculum as we are trained as surgeons. And it's a big gaping hole.
Yeah. I mean, when you feel that you've seen something, you kind of feel, why can't everyone see this? But I do still remain really surprised. And you've heard me say before, this is an absolutely ubiquitous surgical experience that we don't talk about at all. And I've commented that I've had, I and many others had many great surgeons who taught us many things, and had the foresight not just to teach me how to tie a knot, drive a needle holder, or nowadays drive a robot. They had the foresight to educate me about some other skills, about breaking bad news, talking to patients, dealing with colleagues, writing research grant, starting a private practice, whatever it might be that wasn't absolutely pure surgery. And yet no one ever said, oh, there's one other thing you need to know. You're going to be affected when things go wrong. And I still find that bizarre. And I suppose that's one of the things which still motivates me.
Why do you think that is, Kev? Why do you think we've had this whole, why do you think we don't talk about complications?
I don't know all of the answer to that, but part of the answer um, is cultural. And when culture becomes embedded, it's much easier to adapt to a culture than to change it. And that's an obvious statement. It doesn't just apply in surgery. But what you realize is that once a culture is embedded, people don't question that culture anymore. And so there's something about surgery that at some point developed into that that you need to be tough, and that toughness equates to never admitting to fragility or frailty. And of course, we now know that true toughness means being able to face up to fragility and frailty. But there was something, and is something, about surgical culture that says that you need to be tough and to fail to admit to frailty and fragility. There's something that we've confused resilience with not being affected by complications. And of course, now we understand that resilience doesn't mean you're unaffected. Resilience means you're able to bounce back. But the culture told us that if you're resilient, you actually are not affected by complications in the first place, which is nonsense. There's something about saving face, about maintaining reputation, about not being seen to be vulnerable. So I think all of those strands run through surgical culture, which is hard to change. And when you think you're the only person experiencing something, you're much less likely to share it with your colleagues.
Yeah, I agree with you wholeheartedly, Kevin. I think that's one of the major issues is if nobody's talking about it, it's not okay to talk about, kind of implicitly in the lack of that conversation. And what's so important with your work and getting out there and speaking at the American Urological Association and the Society of Urologic Oncology and the British Journal of, and the British Society of Surgery and all of the places you've kind of spoken and shared this message is that this conversation is normal. As you put it, this is an absolutely ubiquitous experience. We all go through this and we should be talking about it. And I think it's such an important lesson and an important thing to kind of hear from people who are growing up in the field. And I'd say the other, I'd be off if I didn't say this in a mindfulness kind of based podcast is, you talk about confusing resilience without being affected. And you have to understand how you're affected to be able to deal with it. And one of the real benefits of a mindfulness practice, however you want to practice mindfulness, whether it's through yoga and meditation, you and I briefly before we hit the record button on, we're talking about cycling, active activities. These are all mindful experiences. And what they do is they help you be aware of yourself and your situational self. What's going on in the moment? How am I feeling? How am I experiencing what's happening right now? And you can't help yourself through a complication if you don't understand how it's affecting you. And I think that's one of the major issues that we all struggle with is first understanding, yeah, I'm stressed. This feels terrible. And then dealing with it rather than just pushing off those feelings.
Sure.
I don't want to spend a ton of time on data, Kevin, because it's written in publications. You've spoken about it. It's there. But when people ask about, or when you give kind of the brief synopsis of data, what are the data points surgeons need to know about complications and the way they affect us?
Well, I've summarized the impact of complications as something which is both deep and wide. And I guess I kind of like that phrase. Deep because of how profoundly we're affected. So some headlines would be, 50% of surgeons after an adverse event admit to being increasingly anxious, 40% admit to sleeping less well, 30% admit to being more angry, both in their professional and personal environments, 10 to 15% admit to drinking more alcohol. So, if there's something that happens in your life that has a 40% chance of affecting your sleep and a 30% chance of making you angry with people that you wish you weren't angry with, then that's deep. That's a deep effect. And it's not just our data from a UK survey, but many other excellent studies from North America and elsewhere, and wide because of the number of different ways in which we're affected. For example, I've talked about some, I guess, emotional, psychological aspects, anxiety, anger, but physical aspects, sleep, physical health symptoms, exacerbation of existing underlying health conditions, professional aspects, concerns about reputation, about professional sanction, professional aspects about your practice. Should I continue to do this operation? Which is a really interesting question, because you might be excellent at it and your team might need you to continue to do it. But because you're worried about it, you give up something that you really should be continuing to do. Obsessive checking, over ordering, tests. So deep, because we're profoundly affected, wide, because it impacts on just about every aspect of physical, psychological, personal, and professional aspects of our lives. So I guess my message would be: do not underestimate how the business of doing surgery affects surgeons.
That's a great statement, and I love that the deep and wide is really easy for people to digest. And I think we've all seen this happen where a junior partner, junior faculty member, if you're in an academic practice, or just a junior partner in a non-academic practice, has a major complication and cannot rebound from it. And it's devastating. It doesn't happen that often, but it does happen. And that's a major loss for the field, for the person. Somebody who can, have a huge impact on a number of patients is no longer able to kind of do that because of the psychological distress that these complications can have. Have you experienced that, Kevin? Have you seen that?
Yeah, I think I have seen that. The sort of the catastrophic example like that, where someone who was able to practice is no longer able to practice, is fortunately pretty few and far between. I guess more common is a sort of insidious grinding down and erosion of confidence. But for sure, I've seen both, and I've really seen the acute psychological morbidity that comes from people floundering after a complication, and, dare I say it at this point, being under supported. And one of the things that we've become interested in is the sort of support vacuum, which all too often seems to exist in the aftermath of an adverse event.
Yeah, we're going to get into the support vacuum and how we can kind of improve that, or help get rid of it. But I think when training residents, and I spent a lot of time with residents over the last 15 years, you see residents who are incredibly self-aware, and we have partners who are incredibly self-aware. They know what they're good at. They know the operations and the kind of practices that stress them out, and they gravitate away from those things. So whether they have kind of a formal awareness practice or not, they're aware of what they enjoy doing. And I think that's one of the way we protect ourselves in surgery. But then we see the completely unaware people who put themselves in bad situations on a regular basis, and sometimes feel, we tend to think, or the reflex answer would be, oh, that person, the complications don't affect them. It doesn't bother them. I think it affects them deeply. I think there's a real struggle that those people go through, who don't necessarily understand why they keep having these awful situations and these awful feelings. And I think we see that too. And it's tough in how we educate people on that and help them understand who they are and what's going to help them have a meaningful and fulfilling career.
So that who they are question is really interesting to me, and this might be an area that we're beginning to explore, because of course there isn't one size fits all in terms of how we might respond to complications. How we might respond to complications and errors depends on who we are in the first place. At least I think it might. We all bring personality characteristics to our surgical practice, and thank goodness we do. I mean, isn't it great that we're not all psychologically similar? Surgery would be the lesser if we were. So I often say to really junior doctors, don't shy away from surgery because you think you have to be a certain type. You don't. And surgery welcomes people with all personality characteristics. But what if an understanding of our personality characteristics gave us some insight into how different kinds of people might be affected by adverse events? Now, we're a million miles away from suggesting that you can really individualize psychological preparation and post-event support. But I am interested in the idea that what we are like could be important in understanding how we might be affected by adverse events.
Yeah, I think it's really important, Kevin. I think you're probably spot on, right? I mean, we react differently to physical situations. We react differently to emotional situations. We each need different things. So it would be naive of us to think that there's going to be a blanket statement or a blanket response that should happen, anytime there's a complication. I'm sure there are similarities we can, put in situations, but we're each going to need something different.
Sure, and that ties into the discussion we had a moment ago, Phil, about the bizarre nature of us ignoring talking about the impact that complications has on us when we're training surgeons. I would add in a tiny extra strand to that, which is we also do ourselves a disservice if we don't spend a little bit of time understanding, what sort of people we are. And I would see that as a really valuable part of surgical training as well.
Yeah, it's one of the things I work. I don't know if you know this about me, Kevin. I coach. I've gotten certified as a coach, and I love being a surgical coach, not necessarily in the operating room, but working with surgeons on all of the stuff out of the operating room that you and I are talking about today. And one of the first things we work on is really defining and understanding who you are. We each have different personalities. We have different energy kind of levels and baselines that we return to. And when you're fighting against that, it creates cognitive dissonance. That's the, kind of psychological term. And complications are actually a major source of cognitive dissonance when they happen. But a better understanding of who we are and how we react in stressful situations can help us deal with stressful situations rather than doing what we see. You and I could be partners. We could work together. I see you deal with a complication or an issue in one way, and I try and emulate that, but that's not the correct answer for me. I really need to understand
Sure,
how I need to get through it. And I think that's part of it.
sure, sure.
So we talked a little bit, or you touched on this support vacuum. Tell us a little bit about what that means, and then we can start talking about ways that as individuals, as institutions, we can work through that.
Um, I mean, first of all, it's important to acknowledge that surgeons have always supported each other, and it's really important not to be dismissive of the wonderful support that surgeons have given to each other since surgery began. And that support, and you've heard me say this before, Phil, often includes, but is not limited to, encouragement. Intended encouragement from a retelling of something that happened to somebody else. What's happening to you, it happened to me, let me tell you my story. Also some reassurance from colleagues who say, look, you're good, I'd let you operate on me, I'd let you operate on my family, and some encouragement to get back into the game and get back into doing surgery again, and all of that's good, and that support is usually always well-meaning, I hope, and very often beneficial, but not always beneficial, and actually is inadequate for the breadth and depth of the impact of adverse events that we just spoke about. And in the 21st century, with our understanding of psychology and resilience and so forth, there's a recognition that surgeons need more than just that sort of backslapping encouragement. But what really drove us to think about this was the huge number of emails and conversations we got from surgeons when we started speaking about our work, where they said, please, can I tell you about what happened to me? My employing institution didn't know what to do. And we hadn't gone looking for that strand of work. We were kind of interested in reporting the impact that adverse events have on surgeons, and we were kind of interested in whether or not surgeons can be prepared for adverse events. But we got nudged into looking at post-event support because surgeons said, people don't know what to do. People don't know what to do. And my employing hospital, they were good at discharging the medical legal aspects of duty of candor and stuff like that. And they were good at making sure that my notes were contemporaneous, and they were good at making sure that I'd spoken to my indemnifying organization. But they were absolutely appalling at checking if I was okay. And they were equally bad at some of the banal, mundane, but incredibly significant things like, should I come to work tomorrow? If I do, what am I going to do? Am I going to be budded up with someone? All that kind of stuff. And so the various people who speak into that vacuum have a particular perspective or agenda. but we just felt that there was no coordination, a myriad of things clamoring for a surgeon's attention, no coordination, and no focus on the surgeon's well-being. And one surgeon who corresponded with me said, "I felt like a criminal. In fact, I was just trying to do my job." And I just thought, we can't we can't have that. If adverse events are ubiquitous, we're all going to get them. And I'm not denying that occasionally surgeons are culpable, but we can't have people being made to feel that they've committed a criminal act, but that's what people were telling us. And so we became interested in supporting surgeons after harm.
Yeah, I think it's hugely important. One of the data points we didn't go over was the amount of attrition happening in the field right now. Surgeons were losing to burnout and a variety of other terms, or however you want to do it. But one of the major sources of that is actually complications in the US, fear of litigation. I mean, these things are major insults to someone who's dedicated decades of their life to helping people. And yeah, you're right. There are certain times where we are culpable and we've all made mistakes. And I would hope to think that 99% of those mistakes are done with good intentions, right? There are very few people out there who are intentionally harming people or intentionally
Sure.
doing things in a dangerous way that put our patients at harm. But yeah, it's a really important source of burnout and losing surgeons. And I want to talk a little bit about go back to the individuals a little bit. We talked about how surgeons support each other. And I think about this a lot. And I think about the people who've helped me and how they did it when I was especially early on in my career and I had some, major complications and issues. And I think one of the really important things, you talk about retelling, and we all share our stories, we all have our experiences. We have to prevent from being a show of one-upsmanship, right? Oh yeah, that's not so bad. Guess what happened to me? And it's okay to share
Absolutely.
those stories. And I actually think that helps people bond. I agree with you. But I always encourage people who are interested in this to just listen. That person just needs you to listen. You can tell your story, and that's a way to connect, but don't put them one up. Don't tell them about something that happened to you that was worse. Don't happen to tell them about the time why your life is worse than theirs. And their experience is real and it's profound and it's awful for them in the moment. And sometimes they just need someone to listen.
Sure. Completely agree, of course. I mean, absolutely, let's not downplay the importance of retelling. And in fact, one of the things that people have told us has been so striking for them is to hear senior surgeons bare their souls. And you've seen that done in a public environment. It is extraordinarily helpful for surgeons in training and junior surgeons to hear a senior surgeon explain how they felt when something went wrong. So I'm really a fan of retelling, perhaps particularly in a sort of group environment, but in an individual environment where someone is needing immediate support, the as you said, the sort of complication one-upmanship has limited, if any, value, I think.
Yeah, and I think it just comes to one of our basic principles of being a good leader. And once again, to take a mindfulness spin on it, people say, what are, if you had to break down leadership into, core components, I think that the two major ones for me that I always push people, if you want to lead a group, express gratitude and someone, but express vulnerability and sharing these stories, telling people that you are vulnerable. You've been in the same situation that they are in right now really helps bring people and groups together. And I give you a lot of credit for leading these charges at meetings. I mean, I think the SUO was one of the most incredible events I've ever seen for audience members who aren't familiar with the Society of Urologic Oncology. Kevin came and gave a lecture and then basically led a group session of about 400 to 500 surgeons in a large ballroom who just got up at microphones and individually shared stories of personal complications and how they were affected by them. And it was one of the most profound events I've ever experienced, particularly because how personal it was. And the SUO, for people who don't know, is a very regimented academic meeting where people wear dark suits and ties. And, it's very traditional and very much an old boys club that those barriers are kind of being broken down. But to have people talk about how they felt and how complications affected them was tremendous. And it was an incredible experience for those involved.
Thank you. Yeah. And yeah, that's been our experience when people hear surgeons talk about complications. I'm almost at the stage now when when I'm asked to speak about this, I pretty much say to people when they ask me to speak about it, I will do it, but please, will you arrange locally for surgeons, for a surgeon or surgeons to speak about their own experience?
Yeah, I've had the same experience, and I get asked to talk about this as well too, and kind of lead discussions. And they say, "All right, we'd like you to give a 40-minute lecture." And I said, "No, we'll do 20 minutes of talking, and then 20 minutes of the audience talking. They need at least as much time as you're on the microphone as they do to kind of download it and speak." And those conversations, I always ask to be the last kind of lecture series of the day, so people can spill out with these conversations into wherever they're going, because it has huge impact on the rest of the day. The other thing is individuals we talked about, Kev, was the reassuring, like, hey, you're a good surgeon. I'd let you take care of my family. But one of the things I think is incredibly important too is that we can't gloss over the details of what happened, and we have to be incredibly honest with each other. And as I've come up with my paradigm for dealing with complications, and I think one of the most important parts at the whole point of this is to get to the truth at the bottom and understand why this happened, what could you have done better, and prevent it from happening again. And that's been a source of resilience for me, is kind of making it mission-based. All right, this was a bad thing that happened. Most of the time, there's nothing we could have done to prevent it. But in retrospect, what could we have done differently so that if we ever encounter it again? And that came from, honestly, kind of variations on something called the after action review. I don't know if you've ever seen this. This is from the Navy SEALs and the military, the US military, who does these really intense debriefs after missions about what we could have done differently. And I won't give the whole analogy, but the quick analogy is, a mission could fail because, weather was bad and it never happened. And we do that all the time. We blame complications on biology, whether in our field cancer, we say, oh, that was bad cancer, that's why bad things happened. Or like you said, that patient had heart disease that we weren't aware of. So there was something about the patient that made things go wrong. And that may be true, but there's almost always something we could have done differently. And you even alluded to it. Well, now we get cardiopulmonary testing before surgery because we don't ever want that to happen again. And it's catastrophic when it does. So the truth and seeking the truth and becoming better, I think, is a major driving force in whether we want to call it resilience or overcoming these complications. At least for me, I don't know what your thoughts are on that.
Yeah, I mean, I think that's absolutely right. And that sort of analysis, tremendously valuable, and of course worthwhile, because what we all want is for our patients to have better outcomes, and analysing the factors that contribute to an adverse outcome and looking at what we could do better is, of course, absolutely critical. I am interested in whether we are always right in where we ascribe the reason for that adverse event. And this, I've got this interest in errors versus complications. I'm aware, even in our conversation today, Phil, and I'm sorry about this, I've been rather loose with terminology. We've probably used complications and errors interchangeably. And that's frustrated me about the literature, because I could be wrong about this, but I still am attracted to the thought that we're not always right when we think that it was my fault. Now, we could be wrong in both directions. We could think I'm not culpable when I was. But my guess is that we tend to ascribe too much culpability when we're not. And I think there is a difference between errors and complications. And I'm really interested in whether the way we immediately frame something post-event then colors our ongoing interpretation of that. And this is one of the reasons why I think that sort of peer support should be rapid. We know that from other sort of situations that cause post-traumatic stress type symptoms, is that quick is important, because helping someone to frame something appropriately could be valuable. Not all adverse events are errors, and there is such a thing, I think, as a pure complication. Yes, we absolutely must look at how we respond to that complication. Were we adequately prepared? Could we have done things differently? But there's something about blame and a decision made about the degree of personal culpability, which is interesting to me.
I love that, Kevin. So it's a perfect segue, because where I was going to ask you is, so kind of institutionally, and I know institutions have different levels, but as an institution, how should we be dealing with this? I'm the chief in my hospital. There's 5 urologists I work with, but I'm in a bigger system where we have 20 urologists. How do we institutionally deal with complications when they happen to others around us?
Well, I think that uh, at the moment, I think that peer support is the way to go. I think there's something about being supported by other surgeons which is truly valuable, at least for the vast majority of situations. Now, I recognize that these things can lead to genuine psychopathology, which require experts to deal with it. Um, but most of the time, I think a surgeon with with the right personality characteristics and a modicum of training is the right person to provide support. So at the moment, I think surgeon to surgeon. At the moment, I think quickly, within 24 hours. And at the moment, I think locally. Now, that's a really interesting question, because some people would say, I need to be supported from someone outside of my institution, because being supported from within my institution brings too much potential baggage about reputation and showing vulnerability. And so some people would advocate for being supported by a peer and quickly, but by someone from elsewhere. The downside of that for me is a lack of awareness about the actual local environment. Sometimes a lack of awareness about what support might be available locally. And there's nuances to this. You know, is the chaplain the right person, or is it in my world what we call occupational health or staff psychology support or whatever? And so understanding the local, for the peer supporter to understand the local situation, I think is good. That's my current thinking. Others advocate yes, prompt, yes, surgeon peer-to-peer, but maybe from someone elsewhere. And the whole question about whether it needs to be specialty specific is interesting to me. I think not. I think that there's a commonality amongst surgeons that doesn't require the person supporting me to be a robotic cystectomist, which is what I am. But I'm really happy to be challenged on those thoughts. You know, one of the I suppose attractive things about working in this space is that when there's nothing, pretty much anything is better than nothing. And the time will come in a few years' time for us to really debate, you know, whether it should be within your institution, whether it should be within your specialty. But actually, at the moment, just doing anything, it would be great.
Yeah, I think that's huge, Kevin. Right, just talking about this, normalizing the conversation, normalizing the experience. I'll just highlight some of the things you said, just to kind of sum up. You know, quickly within 24 hours, surgeon to surgeon, specialty specific, in and out of the institution. I think those are great questions, and I will tell you some of the worst complications or errors, however we want to specify, early in my career were multi-team surgeries, and I was helped most by senior surgeons who were not in my specialty, actually, who pulled me aside, said that was really tough. You're doing okay. I've had, you know, same things we talked about before. I've had this happen. This has happened before. This is how we do with it. Let me go with you to talk with the patient's family, and then I'll be with you when we talk to the patient later. And those were tremendously valuable experiences. And I've tried to pay that forward moving forward. I think in an ideal world, the institution question, I'll give my 2 cents. In an ideal world, the support would all come from within our institutions, but we're naive to think that we all have every institution has a perfect working environment where that would be culturally appropriate. And
Sure.
we should strive. And I hope the surgeons that I work with, that they would come to me and we could have these kind of conversations. But if they didn't feel comfortable, absolutely, quick support out of the institution would be better than inadequate support kind of from within. So
Sure.
I think we have to, once again, be aware of not only who we are individually, but who we are institutionally. And while we should strive to be the place where it's safe to have these conversations, we're not all there yet.
Sure.
What about, you asked questions before, should I come to work the next day? Should I operate the next day? Should I have some mandatory time off? In other fields, bad things happen. You're given relief of duty, paid relief of duty often. You know, what do you think about those things? Any data to support those statements in
So
surgery?
I think that exclusion from work is almost always bad and almost never necessary. Now, the almost there qualifies that, because there are situations where an adverse event is due to such egregious or potentially egregious behavior by a surgeon that the only safe thing the institution can do is exclude them. You know, they were under the influence of alcohol, drugs, they committed something that at least initially appears to be so potentially risky to them and their patients that they need to be excluded. But I really think that that is almost never. And surgeons, like all humans, are herd animals. And what we fear the most is being excluded from the herd, is being ostracized from the group, is being singled out and cut off. And exclusion from work does that. So I think that it's almost never right to be left at home looking at your garden and waiting for the phone to ring, and almost always right to come into work and to be amongst the herd where you can be best supported. That's a general principle. In terms of detail, should you go into the operating theatre the following day and do the same procedure? I don't know, and I think that needs to be much more individualized. It depends what happened, who you were with, but it's a general principle. Buddying up with another surgeon, doing a few cases together, or perhaps take the situation of death on the table, which has happened to me. Going straight back into theatre when you've had a death on the table is a pretty tough thing to do. And so a couple of days of doing outpatient clinics, day surgery, some of the admin that we will have to do, but still being part of the herd might be a better way to go. So hard to generalize, except I will generalize on the excluded from your place of work is almost never good, but happens, but absolutely happens. It happens in the UK at least.
Yeah. I've never seen it happen, to be honest with you, Kevin, but I'm sure it happens here as well too. And I agree with you. I think that's the hardest thing, right? The old idiom about getting back on the horse. I think it's important to stay involved in clinical care and clinical medicine. All of a sudden becomes kind of what could have been kind of a bump in the road becomes a huge mountain that you have to overcome.
Sure.
I think sometimes the further you're away from it. One of the things I've tried to do, and whether right or wrong, I remember once again my profound experiences, and thank you for sharing about death on the table. I've had my share too, and it's tough when you do big pelvic and retroperitoneal cancers. These terrible things can happen in the operating room, and they can have profound experiences on you. And like you said, just being part of the herd and knowing people are around the following day, the following week, can help reduce some of that anxiety and worry about things. So I always encourage people, especially junior people, have this: ask for help, ask other people to be around, and to kind of live that in reverse. Now in a leadership position, I just try and be present in people's operating room, whether they've had something bad or not. Just poke in. Hey, how's the day going? What do you got going on today? Kind of look over the field or take a look at the screen, just letting them know that I'm around in a non-judgmental way. I just know you had something bad happen the other day. Here for support if you need it. You got any questions about what's going on today? Not that I'm looking over your shoulder, worried about what you're doing. And that's the hard balance, is trying to impart that you're there for people without the judgment. And
Sure.
that comes with kind of leadership and experience. And I'm not sure I'm great at it, but I try. Kevin, you run or running a randomized trial and kind of some real data sources in this space. And just to make people aware, I will put Kevin's publications, major publications on this in the notes from the podcast so you can access them, because I know some people really do like to look at the data. I do. I think it really helps, as kind of a surgeon scientist, as we all are, to help it solidify a little bit. But tell us a little bit about trial and data and where you kind of think the field is going, and whatever you can share with us in that space.
Sure. So let me begin with complete candor and openness, then, seeing as that's what we're talking about today, and say, we've had struggles getting our trial into print. Not that I mean that it's been rejected, but we haven't got it to that stage yet, and that's a frustration to me. I share that because actually any original research is incredibly difficult to do, and we're a small team, limited funding, buffeted by COVID, and it's been a challenge. And I'd like to confess that I've spoken about our trial enough times for people to think, that's great, where is it? And I don't want to fall into the trap of, presenting an abstract at a surgical, how many surgical abstracts turn into publications, very few. But folks, it is genuinely, it's coming. What do we do? Well, we said, can you prepare surgeons for adverse events? Now, it's important not to make too big a jump here. you can't deliver training to someone and then analyze when an event happens, whether they are better prepared for it than they would have been had they not had training. You just can't do that. I don't think that's possible. Events are too infrequent and too varied in nature, and response to adverse events too individualized to demonstrate that you can prevent someone being affected by an adverse event. So we took surrogate markers of how prepared people are, and those surrogate markers were validated measures of things like resilience and psychological flexibility. Now, to surgeons who aren't believers in this, that might already be a step too far, but people need to bear with me on this, because outside of medicine, in workplace-based psychology, there are validated measures which are so widely accepted that people don't question whether they're true. So there are measures of psychological flexibility and resilience. And the question we asked was, can surgeons, from a reasonably simple intervention, be improved in those measurable indices? That's what we set out to do. And we took around about 75 surgical trainees, randomized them to receive or not to receive 3 2-hour sessions with a PhD student with a background in undergraduate psychology, but no particular skills. And we trained the PhD student to deliver a psychology-based, actually broadly mindfulness type intervention. It's called ACT, acceptance and commitment therapy, but it's basically based in mindfulness. And then we measured those various indices before, during, and after the intervention. And I've shared some preliminary data from this. And, you know, I'm pleased to say that the preliminary data shows measurable differences in validated measures, for example, the brief resilience scale, and measures of psychological flexibility, and measures perhaps particularly gratifyingly of self-compassion, which we haven't spoken about, but we know that self-compassion is a predictor of future psychopathology. So I mean, in some ways, this was proof of concept. Will surgeons engage with one-to-one based mindfulness intervention? That's perhaps the most important outcome of our study, and the answer to that I can say unequivocally is yes. And does that intervention help them? I think so. Now, as I began this little section by saying, it's a big leap to say they'll be less effective when something bad goes wrong, and I think, you know, that may never be provable. But surgeons can be trained in resilience and psychological flexibility. Neither of those things are resilient things. They themselves can be modified. Again, that's a given in the workplace-based psychology world. And that's what we set out to do. There isn't much literature in this. There's a few other proof of concept papers out there that basically say, yeah, we were able to get surgeons to engage. But that's where we are with this at the moment.
It's awesome. Thanks for sharing, Kev. And yeah, I think it's really important that, you know, in surgery, in medicine, we're so ingrained to be black and white, right? We need data, and things like validated questionnaires and data are super important for showing objective outcomes, for funding sources, for all of these things that are important in academics. But once again, I get asked to talk about these things just like you do. And I say, yeah, there's black and white, but there's a huge gray area here. And if we can subjectively make you feel better about your experience, about your day, about your week, about your month, you are much more likely to have a healthy and happy surgical career that is sustainable for decades. And that's the real end goal. So I give you a lot of credit for putting black and white to it and giving us some data. But at the end, if we can just influence the way people feel on a daily basis, we're doing good. And I congratulate you for doing that.
Thank you. I mean, you know, it's difficult to know. We had a control group who didn't receive the intervention. Of course, it's difficult to know what the positive impact would be if someone nice sitting down with someone for 2 hours and saying, let's talk about you, would be quite independent of whether or not there was a specific mindfulness-based intervention. So loads of unanswered questions and lots of fertile ground for future work. But it's an exciting area to me. As to can we help each other sort of prepare for the rigors of surgical life, not just the impact that adverse events have upon us.
Yeah, and I know your work builds on some of the body of work by Carter Labaris, who was a guest on the podcast last season, and Carter's amazing. And we're working on kind of building in an enhanced stress reduction technique for our junior faculty I think the work on trainees is phenomenal. And I think that's ultimately where we need to start and where these trainings should begin. But we've kind of missed the boat on generations of trainees. And so starting to look at junior surgeons and junior faculty members too, to see if we can make impact early in a career for sustainability. And once again, how do you measure sustainability of a career and how do we improve that? I mean, that's really hard to do, but once again, kind of providing the foundation and the framework for it. So where do you think moving forward, Kevin, in terms of kind of curriculum, surgery, and I would just say your work is tremendous. And I think my hope is within 10 years, this is curriculum. This is no longer the soft part of, our surgical training. Where do you think it fits in now, and where should these discussions and preparing people for complications, where does it fit in and how should it fit in?
So in some ways, I think my aims are relatively modest. I would like it to be that at some point in surgical training, there was at least an acknowledgement that we know something about how adverse effects affect us, and an acknowledgement that what you are like as a person is a moderator of how you respond to adverse events. Do you know what? You could cover that in an afternoon. In the entirety of someone's surgical training, you could cover that in an afternoon. And for me, that would be a huge win if every surgeon had that. Yes, I'd like it to go deeper than that. And I'm really interested in a greater understanding of who we are, our personality types. And I hope we might have a piece of work coming out, because when we did our national survey in the UK of the impact of adverse events on surgeons, there wasn't too much forethought in this, but we collected some pretty detailed psychological profiling. And so our respondents, we know what they are like in terms of their personality, and we're interested to see whether or not that affects how they are acting to adverse events. But for now, just some basic education when surgeons are training. That's the first relatively modest aim, I think. The second relatively modest aim is that every institution where surgeons work should have some kind of peer support. And I think it's hard for this to be harmful. I acknowledged earlier on that the way in which surgeons have supported each other for generations is broadly good. And what I want is something that remains broadly good, but just is a bit better than that. And that is about some kind of peer-to-peer support. And I think that you can train right-minded surgeons to deliver that kind of support in half a day, and we've trained a cohort of surgeons in my institution to be the first port of call for peer-to-peer support. They need some understanding of the psychology of this, some understanding of what's available locally, and a good understanding of how to onward signpost for people who genuinely need specific professional intervention. And you know what those two aims would do for me? That we educated people on the way, and we supported people after events. That would be great. If we could achieve that in a decade, then that would be fantastic. I'm not naive to how difficult it is to change prevailing culture.
Yeah, I love those thoughts, Kevin. And I think it's simple and profound. And we've talked about how to do it. We have a wellness curriculum now in the residency. And so every so often, kind of complications and management of these things will come up, as well as does professional development and dealing with contracts and negotiations and all of these other things that are in the softer side of surgery. But I've also thought about just having a retreat, we have these retreats for professional development and kind of divisional development, but surgery wide, just get people together once a year and say, okay, let's have this out. Let's talk a little bit about when things go bad. And once again, to normalize the conversation, to acknowledge that these things go on. And it might be, I think, more because every time you've given a lecture and we've given these lectures and see people in the room stand up and share these stories for hours, why don't we do that locally and give the people we work with on a daily basis the experience to kind of share and develop this joint vulnerability? So I've thought of that too. And I love the peer support network. And it's going to take me a few days to formulate an email, but I'm going to our chair of surgery with this. I think this is something we can do short term really quickly. That's a great idea, Kevin. And like you said, we do it informally. Let's make it formal. Let's make it proper. And I think that's something we can all do at a kind of short term level. Mm-hmm. So we're getting close on our hour, and I want to be respectful of your time. And we've both got days ahead of us. Is there anything we didn't cover that you want to go over? Anything that the audience needs to know about this issue, these issues, and how it's either affected you or how it can better affect them?
No, I think so, Phil. I think you've marshaled our joint thoughts expertly, and thank you. It's been a huge delight. One thing we didn't call out specifically is that surgeons are not superhumans, and I think it's a myth that we are super resilient. I think surgeons are ordinary people doing an extraordinary job, and if that's the case, then we need to look after each other. I simply don't believe that we are either a self-selected, particularly resilient bunch, or that the wonderful nature of our surgical training makes us resilient. I think we're pretty ordinary, and I guess if I can add to my list of modest ambitions, I'd like it to be a recognition of that. Actually, would be valuable. But no, I think we've had a really fascinating and wide-ranging discussion, and I'm really grateful to you for your podcast and for being willing to infuse and engage with this area. Thank you.
Well, thank you, Kevin. Thanks for leading the way and setting the example of what surgeons should be and what the things we should talk about. And once again, kind of normalizing this conversation. So I just want to summarize for the audience some of the amazing things you've said today for us. And we started talking about your kind of career. And I think once again, it's important to highlight academics can take many different shapes and forms, whether you're in an academic institution or not. You can pursue things that aren't traditionally thought of as academic. And so if you get that itch 5 to 10 years into your career where you want to answer a question about surgery, about life, about whatever it may be, go for it and decide where that's going to go. I think really important, you talked about this being an absolutely ubiquitous experience for surgeons. We all go through this. We all experience complications or errors, or however you want to put it. And these can have deep and wide influences on who we are as a surgeon, affecting us profoundly, and it's affecting a large proportion of our life. We talked about how surgeons can support each other, both individually, where we retell stories and listen, where we reassure each other and seek honesty, but then also how institutions can do that. And as an institution, we can help each other by being there quickly within 24 hours. We can talk surgeon to surgeon. We can provide support and keep people at work, keep people focused on the things that they do well and help them overcome these insults. And lastly, we talked about your trial and the data and how I'm taking home one of the major points, exactly like you said, that surgeons can be mindful and that we can employ these practices, and surgeons will actually say yes to do these things because they want to be better. They want their experience to be more enjoyable and more sustainable. Nobody wants to be stressed out at work. So as we work towards, acknowledging that complications and errors happen, that they affect us, that we can create institutional peer support, the last thing you said is we are not superhuman. We are ordinary people who do extraordinary work. And I think that's a major take-home message. And I think that will be the theme of our podcast and very likely the title, Kevin. So I want to thank you for your time. And I hope you have a wonderful day. And it's always great talking with you. And I hope to see you in person again soon.
Thank you. It's been a delight.